Welcome back to Mic'd Up with ChiroUp. Today's episode is a bit of a mashup, really in the best way possible, because we took a step back and looked at some subscriber feedback questions, and really, yes, I read all of them, to answer some questions from the last podcast. And we're going to circle back for the first part of the podcast, and we're actually going to build on some of that knowledge, especially when it comes into the connection between cervical dysfunction and jaw pain. Then we're going to step onto the playing field, literally diving into how we evaluate, diagnose, and manage growth plate injuries in youth athletes. This is something that I see every week, both in clinic and also on the sidelines. And honestly, it's become a natural extension of my practice. So if that's something that sounds kind of cool, I think that's something that can help build all of our practices, because we take care of adults and they bring in their kids, and before you know it, you're the go-to for the entire roster. So let's be real, parents will invest unlimited amounts of money in their kids' performance and recovery faster and more often than they do on themselves. So this space really does matter, even if you don't market that in your clinic. It's a population of people that have a need for chiropractic services, and we're going to walk through the entire thought process, the pitfalls, and the strategies that will actually work. And then to wrap things up, we're going to roll out a new feature inside of ChiroUp, not ChiroUp Essentials, not ChiroUp EHR, the entire platform that's really going to change how your office communicates. Think built-in messaging, test management, and zero need for outside apps. So let's get into it. I'm sorry, I forgot to introduce my new assistant. We hired him a couple weeks ago to manage my schedule, clean the adjusting tables, and perform receptionist roles. Tim, great to have you on the show.
I feel so valued. Did you want those leaves in bags or dumpsters, by the way? I put them in the back of the car for now. So
there was one time where I came out. I was working with you for about 2 years, and I had I think it was a 2002 Camry, and I walked out. He took the hubcaps off the car, put pinstripes on the car, and then took the seat covers and then put those stickers like crossbones on the back of the Camry. Remember that?
It was all for love. I appreciate the warm welcome. I definitely enjoy and can't wait to see what you put together. I've seen the outline, but I really don't know where this conversation's going, so let's jump on.
It's kind of where all the podcasts come from. It's a lot less produced content and more like a safari through the jungle gym of my brain. We do have guardrails that keeps us from flying off the rails entirely. So we do have an outline behind these podcasts, but really it comes down to just kind of chasing rainbows, sprinting after squirrels, and kind of occasionally stumbling into something that actually sounds smart. But to get back on track, let's talk about the jaw, because jaw pain and neck pain, this is something that can influence both the types of patients you see and the outcomes you get. And we're going to cover 2 recent papers that are going to affect your treatment of jaw pain. And I think that that's one of the biggest pieces, is I said affect, net effect. And I had to go to ChatGPT for this one, but I remember from a long time ago in neurobiology classes, there's a difference between affect and effect. And the simple rule is that gets you right 70% of the time, every time, is that affect is a verb, to influence something, and effect is a noun. It's going to be the outcome or result. So whenever we talk about this, it's not the jaw affecting the neck. It's really, these things are going back and forth. It's an action, and it's not one directional, it's bi-directional. So let's dive into these articles.
I'm just watching the listener numbers go down as you go through your grammar lesson here. Let's get back on track. I know this segment is actually coming from user feedback, listener feedback, and it's a follow-up to our last episode on TMD. And the question was, can treating the cervical spine alone improve jaw pain, even if you don't touch the TMJ? And we know as chiropractors that would be awesome, to be able to assess and treat the spine, and then everything takes care of itself. And we know that a lot of problems do. They're largely influenced by the spine. But the question we need to answer is, does treating the spine address symptoms that are related to the problem of TMD, or is it the etiology, especially when we talk about the upper cervical spine? And the answer is yes, it's possible all the way around. But the bigger question is, why would we stop by just adjusting the spine? That if these systems are truly connected, why don't we take the extra 30 seconds to evaluate and look at both of those areas, getting rid of the problem and not just act as a temporary symptom police or an expensive Advil. So that's exactly what we're diving into today as clinicians. It's our responsibility not to just rely on what works, but to understand why it works and to continually integrate new research into our decision making. And there is some new research about TMD. There's new evidence saying how the jaw and the neck and pain in those areas can function together and fuel each other. and what that means for how we evaluate and treat our patients.
So the first article that I found, and really where we find all of our articles, is in our research hub. So go on the homepage to ChiroUp, you can go in the research section, and we have a team of people that just try to figure out what is applicable to chiropractors, and then they try to get that information into ChiroUp, and then also what's applicable to our patients, and making sure that our social media and our newsletters can include that information, so we stay up to date with the new pieces of information that are coming out on a monthly basis. However, this article that I want to talk about is in the Journal of Oral and Facial Medicine. Came out last year in 2025, and I think this is what I want to get across as far as the affect and effect is that when we think about the trigeminal cervical nucleus, which is in our brainstem, the authors explained it as a central wiring hub. And in school, which was a while ago for me, a long time ago for you, Tim, I always thought about things as peripheralization and centralization. And you can go back and read about those, and those things are definitely true, but it's not just centralization of pain. If you put your finger on a hot stove, after a while, your brain's gonna be like, "Hey, buddy, not a great idea. We've done this before," and your brain's gonna already be wound up and excited about even the thought of putting your finger on that hot stove because we learn. However, this paper analyzed 83 studies and how cervical and orofacial pain interact, and what they found is that bidirectionality. That if you have pain in your jaw, it can actually refer over to the head. It can refer into the cervical spine. And it's not just jaw pain causing neck pain, and it's not just neck pain causing jaw pain. It can actually go back and forth. And this is an important piece of understanding this is a shared neural network. This is not just one or the other. So when you have someone who comes in with neck pain, don't just put your blinders on and look at that one. We really want to be able to make sure that we can take an evaluation standpoint for both areas of the head and then the neck. And within seconds, use a couple orthopedic tests on how to make that differentiation. If you have any questions on how to properly assess the cervical spine and how to assess with videos and explanations for the jaw, take a look at the condition reference section for temporomandibular disorder. And it's important to know that it's temporomandibular disorder. It's not temporomandibular joint. How many of your patients come in and say, "I have TMJ"? Like, yeah, you have two of them.
I have elbow. We have another study too, actually a couple that have looked at the connection between biomechanics and function. And there was a 2025 clinical review, and then in 2026 there was an observational study that said that it's mechanical and movement based as well. That the cervical spine positioning can alter TMJ biomechanics. That's not a stretch to think about. And jaw activity can change cervical mobility and movement patterns. So you just dropped your sunglasses on as a little extra bonus here. Was it too bright what was being said? This is nice. This makes for good radio,
Here's the deal: is our content people wanted us to get video of this, so I thought I'd make something really funny. So now I'm wearing sunglasses.
That's the best you could come. You can do better than that. I've heard you can.
You should see what I have planned for this
I've
podcast.
not seen it. The other thing that we know is that it's not just the cervical spine that can alter TMJ biomechanics, but jaw activity can change cervical mobility. Wow. If we have an issue with our jaw, our neck movement actually changes. And then there's a 2026 study looking at the relationship between the upper cervical spine mobility and TMJ motion. So there are mechanical effects, and not just between the jaw and the neck, but between the jaw and the neck and the head. As you talked about, there's this convergence in the trigeminal cervical nucleus where anything that's innervated by the jaw, by the suboccipital area, by the head, by the neck, dumps into this same nucleus. So when one of them is stimulated, all of them get confused, and any one of them can think, maybe I'm the problem, and that's where the symptoms happen. So there's that neurologic effect, but there's also another mechanical effect that we didn't talk about. That's the myodural bridge. So there's been multiple studies, including just a few weeks ago, yet another systematic review that looked at those and said, yeah, absolutely, there is a connection between the upper cervical musculature and the dura. And those muscles, when they contract, they will pull on the dura. And the thought is that it pulls the dura to keep it from buckling as you're flexing flexing and extending your head. But it clearly has a relationship to CSF, and it clearly has a relationship to traction on a very pain-sensitive structure, the dura. So lots of things. Our key takeaways here is that the jaw and the neck move together as a functional unit, and dysfunction in any part of the head, in the neck, in the jaw is going to potentially spill over onto the other.
Well, thank you for going through that review of the neurophysiology and mechanisms of the jaw. I think this is one of the diagnoses very similar to BPPV that we hear about, but sometimes we don't treat. And that's an unfortunate piece because most chiropractors want to treat patients for life. And I want to treat all of my patients for life, just not the same condition. But really, when someone complains about being dizzy or complains about jaw pain, are you able to do a realistic evaluation? Are you able to provide them with the right kind of advice, the right manual therapy, the right manipulation, the right at-home rehabilitation exercise? And if you can do that, and you can do that on a repeatable basis, you now opened up another patient demographic to treat. And that's one of the most important things. So here's one of the things that I do in my practice that is we'll call it Dr. Steele's secret sauce, is that try doing this with your next patient. When you're working on their neck and it's been a chronic issue, just do a little palpation or rub the masseter. And it's like poking on the infraspinatus of someone that has rotator cuff syndrome. They don't realize the sensitivity to that joint. They don't realize sensitivity in that muscle, but until you make them aware, they don't get it. They don't relate their bruxism and their jaw soreness when they wake up to their neck pain. And if you can be the impetus behind this and recognize the connection there that we're talking about, you're opening up another type of patient, another condition that you can treat. I think this is something that if we can do better as a profession, and not to say that we have to get away from the spine. That's awesome. Keep on doing the great work we're doing in the spine. But if you truly want to get busier with more patients, and personally, my own opinion is that new patients are great, but reactivations and re-injuries, that's where the money is. And I say that in all honesty is because they've already bought from you once. You already had great results with them once. Show them something else or somewhere else, I guess, in this discussion where you can help them again, and then they're going to continue to talk about you. Who has had a patient that you helped with their shoulder, and then you become the shoulder guy? They refer someone else for the shoulder. Well, if you treat more diagnoses, you're gonna be the guy or gal for that specific condition in your community. All right, I think that's about it. We can talk about the jaw. I just want to really hone in on just the combined cervical and jaw treatment. Don't be the isolated person. There was a research review that came out in 2026 that looked at the jaw exercises. And what they found is jaw exercises are great. In fact, the chin depression exercise that we use in ChiroUp is my favorite. Try doing that one. It's really interesting. It's fun to watch your patients do. However, don't just do those. Also combine cervical exercise because of that coordinated system. We really want to take the blinders off and look at both systems at the same time. It's kind of like treating the back and not looking at the hips. A lack of hip extension forces extension on the lower back. Don't be a hypocrite of the jaw. All right, let's get into the next section. Let's start with the clinical section, Tim.
Before we jump into that, I have 3 gifts. I know you didn't know that this was, 3 gifts. It was 2, but then I thought of a third. Number 1, they're going to get about a 2-minute reprieve from you. Number 2, a key business strategy that we'll go over. And then number 3, we're going to give you a new app at no extra cost. So let's talk about number 1, or number 2, really, the key business strategy. And that's something that drains efficiency in a lot of practices, and it's third-party sprawl. And some people call it tech debt or click debt. Many of the clinics that we've been part of and clinics that are out there are running what I'd call a Frankenstein system, where you've got a platform for notes and another one for billing and one for texting and one for payments. And maybe you're using Teams or Slack for communication, and then some marketing tools and AI scribes and clearinghouses. And before you know it, you have this duct tape conglomeration for your entire operation. And here's the reality is that each of those systems, it's not just the cost of the subscription for them, it's the cost of the time and the clarity and the accountability. There is something called a click debt that the more times...
Hold on. I'm going to break out rule number 1.
I'm going to give you 2 gifts now. I'm sorry for that.
Because the way I see it is that all the logins we need and all the extra subscriptions, I kind of think about it as like this historical model. We need the best in each area, but really in today's world, those are just widgets. Those things can be built very quickly, and it's just historical things that chiropractors think they need to do, but they don't really need to do. There are systems and platforms that can do it all at once. I like to think about it as like salting notes. Listen, if you're still salting your notes, that is so 1990s. Do you still wear baggy pants? Do you still listen to Mariah Carey and the Beastie Boys on the radio? We just don't do those things in the morning.
There's no need to make this personal.
Well, here's a funny story, is that Tim and I were on the road together on Tuesday, and he wanted to listen to St. Louis Blues. For those of you who watch hockey and still don't know who the Blues are, they're a hockey team in St. Louis. And he turned on AM radio. I did not even know that still existed to this day.
Now you do. You've learned three things. So the thing that we want to think about is how can we have an ecosystem where things really live together, that it's crucial to have the important things you need. You don't buy necessarily everything from one store, that you're not going to buy your clothes from Target, you're not going to buy your auto parts from Walmart necessarily. You're going to go to whatever the best store is for each of those, but there's a lot of times where we can combine some of those things, and that's what we try to do at ChiroUp, is build an ecosystem with everything that a chiropractor needs: documentation, billing, clearinghouse integration, payments, your communication, the AI, all in one platform, so that you're not bouncing around making clicks all day long, no lost messages, no wondering where something lives. And there are a few things that do need to be charged for because there are costs. We didn't even know it going into it, that it costs to send a text. It costs to use voice AI, that those things that we think are free are not free at scale. So we have to pass along those hard costs. But everything else, it's part of it. We're big into it's not nickel and diming. There's no surprise add-ons. And the biggest new addition is intra-office messaging. So if you think of it like Teams or Slack, but built directly into your EHR, you can message your team, you can tag specific patients, you can assign responsibilities to different staff members, keep everything tied to the clinical workflow, so there's no more "did you see my message" or "what app is this in?" And the great thing is that this is going to be available to all of our subscribers. This is not just the EHR, but it's also the essential subscribers. And hopefully by the time this podcast comes out, you'll be getting news on it. We've been using it in our office for a while. It is a game changer. Everything in one place. And it's just not about convenience. It's about running a tighter, faster, more accountable practice. Because the less time that you spend managing systems, the more time that you can spend actually taking care of patients, where our time and our dollars matter.
Yeah, and as a real-world example, our billing company is on it in a secure fashion. They can actually tag a patient and say, "Hey, for Sally Smith, you're missing a diagnosis. Can you fix this for me?" It goes directly to me, not to my manager, then to a Post-it note, then to me, then a Post-it note, then back to my manager, and then back to the billing company. Just from there, I can fix the problem directly from the link. And then I can tell the biller that it's been completed. Within seconds now, I can solve problems.
So you mentioned this. Here's a sidebar. You mentioned this, that the billing company that we used to have in-office billing, you'd have to train a new person every 4 years when they left for a different job because the hospital offered them $2 an hour more, and we had to train a new billing person. We got rid of that headache. So we now have a billing company that's integrated into the platform, which is awesome. What are the other things that you weren't doing 2 years ago that you're doing now that have made a difference in your day?
Oh, geez. What am I not? I'll tell you what, I'm doing more. And the reason I say that is that not as a plug, even though we're really good at plugging the EHR in this podcast, but I honestly don't know how I did notes before Voice AI. I was on a call with a subscriber today, and he's not using Voice AI. And I'm like, why not? I mean, if you could get rid of everything, I would still have to keep that. Otherwise, I'd probably get rid of practice. I'm just a terrible typer. So that's my first thing. Also, I think that now that I'm able to enter in my assessment and it automatically points my diagnosis and creates a claim, I think I have a better vision of what am I actually doing to patients and how am I being reimbursed for that. And I know that sounds kind of weird. I've had a decent clinical hand, but I've had a poor business hand. Because we used to dictate all of our notes and then someone would type them in, and then it was very simple. However, I would lose things on my car ride home dictating. Now I think that I can see the whole system through, and I can see, hey, I'm getting rejections for claims, or something's getting denied, and it can get fixed immediately. Everybody has visibility. And then the last piece is the coordination of care. Think about a Google Doc. That when you're working on a Google Doc, you can have someone else who you're working with across the desk from you who's also working on that document. And at the end of the day, you have a document that's done and everybody's happy with it because everybody has visibility into it. That's your soap note. Meaning if you have different people do your vitals and then you have someone else do your exercise, someone else do lumbar spine traction and high vault, and I'm doing manipulation, manual therapy, and have someone else doing exercises, holy cow, that's a detailed note. But with our system, they're all touching at the exact same time and it's all auto-saving. So I can make sure that I can do the things that doctors need to do. And then my staff can do things that staff need to do. And then the system can automate all the things that neither of us want to do and to get a compliant note. So I know that was more than you asked, but I would almost be embarrassed to go back and look at my prior notes. It's really, now they're so much better. And even with that being said, still faster.
Yeah, just thinking of when you had mentioned the billing company, just thinking about how practice has changed. I think more evolution in the past year for our practice than we had in the past 20 years. It's just amazing the speed, and that's not going to slow down with the right partners.
Well, yeah, but the billing company helped build the billing portion.
Right.
So they know how to use it because they helped build it. I think that's one of the things that I think that's one of the things that make us a little bit different is that
there's a lot of things that make you different.
There's something to be said about people who build something but understand they're not the smartest person to build it, which is us. However, we know how the end product should work. So we brought in experts for all the different pieces to do those. Anyway, let's get back to the clinical side because realistically, actually from the feedback from the podcast, people like to hear the clinical side more than you and I talk. But we're still going to talk. It's our podcast. We can do whatever we want. This is a pretty selfish clinical side because it is going to be all things kids, club sports, real-time evaluation, chiropractic treatment, management strategies for a specific type of patient. But it's going to be on growth plates because this is something that as a personal mission, it really makes me upset when I get misdiagnosed kids in my office. And mostly it's the parents' fault. However, the kid is suffering from overuse and going to soccer, then to basketball, and then training at some kind of facility because college scouts are looking at them at their gym when they're in fourth grade. But really what this comes down to is a pattern of load. And that's the difference we want to make in this conversation. That yes, it's an isolated growth plate injury, but that's not the problem. That's just a weak link. And I think of growth plates like young concrete. It's going to be okay if you put a little bit of load, a little bit, walk on it. However, it's going to take a little bit of time for it to be steady. And unfortunately, repeated pounding, twisting, traction, whatever you're doing to that concrete, if it's not fully cured yet, it's going to start to pull and twist and crack and all the things. And that's what we see in growth plates. So our repetitive impact from running and jumping, our high traction forces like literally the muscle pulling on the apophysis, cutting, sprinting, rapid deceleration, all those things are going to pull at something and the weakest link is going to give way. I do have a fun question for you, though. I'll just think about it as I was talking about those. What sport has the least incidence of a growth plate injury?
Boy, that is a fun question. How'd you come up with that one? I can barely hold back the excitement. So no repetitive impact, no high traction, and you said then no fast running or cutting, sprinting, that sort of thing. I'm going to go base jumping.
Well, you know what? The jumping part of base jumping might get you.
The landing part.
Floating, well, you got to have a parachute.
You don't have to.
Actually, no, then you don't have any pain. Swimming. And I think that those kind of sports, and the reason I bring that up is that we have to think about the sport the person's doing before we can have an idea of why that's happening. Because really it's about recognition of what these problems are. Now, when you talk about a growth plate, recognizing it is actually quite easy because if a growth plate is injured, it's going to be actively inflamed. It's actively under traction or compression stressor. So, feeling the muscles around it, the fascia around it. And really, at the end of the day, digital pressure is going to typically become painful and reproducible at that one spot. And really, the answer is pretty easy. These growth plates are highly innervated at the periphery to help them grow and help understand stress and appropriate proprioception. And unfortunately, though, that inflammation around that injury is going to sensitize those nociceptors. So, I think that's why it happens is pretty easy. Where is dependent on the sport. So I want to go through, and I gave a list of 4 of the most common growth plate injuries. I'm a little more on the lower extremity stuff. The upper extremity stuff is a kind of a different animal. So let's go through these, and we're going to go over the 4 most common lower extremity injuries. Tim, what's number 1?
Number 1, the 2 that you assigned to me that I did homework on were number 1, Osgood-Schlatter's disease. So this is actually the most common one. It's usually somebody who's an adolescent, probably in a growth spurt, as many of these are, and they're doing a lot of running and jumping, oftentimes athletes. In fact, it impacts 10% of adolescents, usually somewhere between age 10 and 15, maybe a little later in boys. And this is going to be pain on the tibial tuberosity, so just beneath the patella, that bump. A lot of times that bump starts to become not just tender, but it becomes more palpably prominent. And at some point in time, it can really become prominent. You see a huge bump on some kids who had this for a long time. And there's really no one clinical test that we can do. When we think of, I'm going to give you a second bonus of this podcast, is here's the orthopedic diplomate program in 30 seconds, that every orthopedic test does one of 3 things. You either push on it, you pull it, or you make it work. So in this case, and if you think of any orthopedic test, that's what they do. Phalanx or reverse phalanx, or have the patient do pinch grip. And when it comes to using that rule for traction apophysitis, we're usually going to push on it, and then we're going to pull on it. So we apply some palpatory pressure over the top and say, does that hurt? And then in order to pull on it, we probably would have the patient do a single leg squat or a jumping task. That would be the most force we could put on it in the office and say, did it reproduce pain at that site?
Yeah, I think we're going to see this with most everything, including prostate disease, but boys are special. Boys take a little bit longer for these things, for that concrete to settle, and it's due to estrogen. We're not going to get too much into that, but just keep that general mindset is that boys take a little longer to marinate.
I have a feeling we're not going to get much deeper into that because that was the depth of your estrogen pool right there.
The depth conversation with the prostate problem. Anyway, next one is Seaver's disease. This one drives me absolutely insane. You'll get someone who comes in your office and the parent comes in, they have Achilles tendonitis and they're 11. I'm like, well, here's the deal. We have a growth plate that's weaker than the tendon. This is a calcaneal apophysis, not a tendon issue. Can you have a tendon issue or a muscle issue? Yes. However, the most likely problem is going to be Seaver's disease. These are your children, adolescents. Really, your field and court sport. We'll see these with sports with cleats because the foot is attached to the ground essentially. Those kids between 8 and 15. Once again, more boys than girls. However, if you see someone in this age group with posterior heel pain and they are doing a lot of running and jumping and running hills and maybe not getting enough rest they're supposed to, this is often going to be bilateral. If you think about it, most of your running sports, jumping sports, you're doing both of them. However, if you look at a running sport, you'll see it usually bilateral. If you think of a jumping sport, it's going to be unilateral because most kids jump off their dominant foot, with running, with jumping, I mean. So any of these things sound familiar. We're really wanting to do a calcaneal squeeze test. We're going to look for posterior heel pain. And it's kind of odd because the way I differentiate between more of Achilles issue and a growth plate issue is that calcaneal squeeze test. If you squeeze that and there is a bone issue, you're going to feel it. If you squeeze your heel and you have an Achilles problem, you're not going to feel it at all. So that's a great way to look at it. These patients are going to have limited ankle dorsiflexion. Do you know of a profession or person that can improve ankle dorsiflexion? Hopefully you do. And then doing some manual therapy to the posterior complex, like the gastroc and soleus, are going to really help these patients because those things are going to be really tight, protecting that injury.
One of the things you said that's interesting about that is cleat sports. So, you're quite familiar with cleat sports, and you know how crummy the support is in a cleat, that they generally have no arch support or minimal arch supports, even good quality shoes. And unfortunately, this problem is where the posterior elements were attaching onto the calcaneus, so that Achilles tendon was pulling on it. Well, that tendon attaches just slightly medial on the calcaneus as opposed to central or lateral. And if you have a fallen arch of the foot, then that's going to rock away and stretch that medial aspect even more. So many times these kids are running miles in the worst possible shoe that you could come up with, and just putting an orthotic or an arch support in there can make a big difference.
In the things that we do. right? The ankle rocker system is that if you don't have good motion at that ankle mortise joint or at your midfoot or the first toe, you can be a Jedi at improving strength and stability and balance. But if you don't get those joints back to normal, we're going to have a recurrent problem.
Yeah, the other one you gave me, Sinding-Larsen-Johansson syndrome, and this is basically the same thing as Osgood-Schlatters disease, except the other end of the patellar tendon. So the inferior pole of the patella, same age group, 10 to 15, especially running and jumping sports, because it's the same stressors. You're just going to push on a different spot. So prominence or tenderness over that inferior pole of the patella, and again, same thing. Have them do a single leg squat or a single leg jump.
Number 4 is slip capital femoral epiphysis. Once again, can't say that 5 times fast. However, it does not make it any more important, or less important, I should say. This is actually a pretty big deal. So if you see a preteen, if you see an adolescent, usually during once again, that rapid growth period between 10 and 15, but we're going to see this in a specific demographic of an obese or overweight adolescent, more often, of course, boys, often with endocrine disorders because those growth plate closures are often due to estrogen release. We see this patient, unfortunately, come in with usually a limp and poorly localized hip pain, groin pain, thigh pain, and it can even be radiating down to the knee. These patients have limited internal rotation of the hip because of this problem. In severe cases, they're not even walking in. So something we're going to want to look at is something called the Draymond sign, where they don't have very good internal rotation of the hip. So when they walk, they have a lot of external rotation of the hip during passive flexion of the knee. So something you can do in your office, take a look at that orthopedic test in ChiroUp. This is a red flag diagnosis. This is not one that we're like a watch and see or rest. This is urgent imaging, so we will really want to make sure that as a provider, we can get this patient into a specialist as soon as possible. 3 of these are really going to be traction apophysitis patterns. Skiffy is a little bit different. The other 3 are things that we can manage. It's one thing that you really don't want to ever do rehab first, and we want to make sure we get this person into imaging once again. All right, so let's talk about what we actually do for patients with a growth plate injury. So this is how we recognize the patients. However, as clinicians, what can we do to help these people get, once, out of pain, but 2, get them back to their sport, and then hopefully prevent it from happening again?
Yeah, number 1 is that recognizing that it's simply a matter that the stressors exceeded the body's ability to recover, that growth plate is the weak spot in the chain. It's 2 to 5 times weaker in an adolescent than the tendons and the soft tissues around it. So that's what gives way. If we think about, an upper extremity traction apophysitis little league elbow, a pitcher puts tremendous force on that elbow. In fact, up to a professional pitcher, up to 100 Newton meters of force. So what that means is basically if you put your arm in a vise, your upper arm, and had your palm up, your elbow extended, if you dropped a 25-pound weight on your wrist from 10 centimeters, that's the stress. The only reason that doesn't completely give way is because there's some muscular control of the area. So we've got to work our way down to that muscular control. Number 1, get the stress under control. That sounds obvious, but it's not always well done. If the patient is sprinting and running and jumping and cutting, and that's the irritation, we need to do something between modifying it a little and taking it away, depending upon how much imbalance there is. Number 2, protect it when it's irritable. And that doesn't mean necessarily putting every Seaver's disease kid in a boot, but if they're limping, if their mechanics are off, or they really can't control that joint without pain, we've got to create a window where the growth plate can settle down. Otherwise, we're just chasing symptoms. Number 3 is once it calms down, we've got to get mobility back to the area, the things that you talked about. And this is where people get impatient. They're not jumping right into aggressive strengthening. We're introducing range of motion, getting flexibility back, especially in the gastroc and the soleus, and making sure those surrounding tissues are moving, that all of the joints are mobile. And then we can get to the point where we rebuild strength and control, not just strength, but control. Those injuries usually aren't just a weakness problem, they're a load management and coordination problem, especially in kids as they're growing quickly. And then number 5, let the athlete earn their way back to the sport. It's not a switch where you say, good, you're good to go, let's go see what happens. It's a progression. Bilateral to unilateral, controlled to dynamic, practice to competition. And if they can't handle the step in front of them, they're not ready for the next one.
Yeah, I think that's the piece that matters the most, is that growth plate injuries are not just about the irritated tissue. It's about how force is being managed across the joint during a time when the body is really changing. I mean, these kids are growing. I mean, their bones are getting longer. Their lever arms are changing. Their neuromuscular system just hasn't quite caught up. I mean, you've seen Johnny at 12. And then you see Johnny over the summer at 13 when he shot up like 7 inches. And then when you see him run, he kind of runs like a deer that was just born. And they lose this coordination of movement. And unfortunately, they've got these prime movers and they have this idea on how to kick a soccer ball or to jump and do a layup. But the agonists and the stabilizers and the timing is just a little bit off right now. And there is one spot, unfortunately, that takes the brunt end of this function, and it is the growth plate. So what do? We really need to start controlling the movements. When we get a patient that's going back into their sport, we need to work on how to squat, how to do step downs, how to do split squats, how to do single leg work. If that's not you as a chiropractor, that's okay. Find someone in your area that does that. Do the first 3 steps that Dr. Bertelsman just talked about, and let someone else handle the rehab for them. However, I will say this, that if you go into ChiroUp in the condition reference section and you want the rehab and you have the time and energy and the desire to help these patients, for patients with Seaver's disease, we give you Valais exercise. We give you the single leg stance. We give you the standing wide balance. We give you all the exercise and video demonstrations on how to do those so you can train your person how to share load, how to control range of motion, how to balance agonist and antagonist activity. Because if you fix that, you fix them. But if you don't fix it, you can rest them, you can stretch them, you can ice them, but as soon as they get back to the sport, the same problem's coming back. Do better. If you get better information, you're better able to recognize it, and you're better able to have a protocol to treat it. We can help this population get out of pain, and then most importantly, stay out of pain.
Awesome. As we wrap this up, if you found value in today's episode, us talking about growth plate injuries and TMJ, the connection between cervical spine, do us a favor, share this with a colleague, send it to a friend, make sure that you're subscribed so you don't miss what's next. But more importantly, give us feedback, because everything we do from this podcast through the EHR, our exercise programs and patient education, it all involves what you tell us, that this truly is a crowdsourced system. The entire system's built around the idea that your voice matters. In fact, recently for the EHR, we've launched something called ChiroUp Vote, that anytime a subscriber has a great idea, we put it on upvote, people can upvote it, and when we get enough votes, that's the next thing that we code. We're getting tremendous traction from that and some great ideas. That's the way the first program was built with Essentials, and that's the way the EHR is being built. If something works, we're going to double down. If something doesn't, we're going to fix it. That's how we move forward, not guessing, but listening to you as to what you need, and we want to know what you need for the podcast. At the end of the day, none of this really matters unless it works in your practice. So keep your feedback coming, keep pushing us to be better, and we'll keep building the tools that help you take better care of your patients. Thanks for listening.